Thank you, Sam. Thank you so much for this very, very kind introduction. Thank you for that. The most important persons today are, of course, not the moderator or the educational committee who has organized this very fantastic clash. Our most important persons today are Federico Di Rocco from Lyon and Mark Proctor from Boston. The topic today, the controversial topic, is the surgical approach to craniosynostosis surgery. And let me start with a remark that both of our presenters have, of course, large experience, not only theoretical knowledge, but practical experience in both types of surgery. The first presenter will be Professor Di Rocco. Federico Di Rocco is a professor of neurosurgery at the University of Lyon in France. And in France, and they're the pediatric neurosurgeon at the Hôpital Femmes Mères Enfants. He is currently the chairman of the education committee of the European Society for Pediatric Neurosurgery. So he is the European counterpart of what is Sandip actually in the ISPN. He was, or he is member of the AANF Pediatric Neurosurgery Committee, and to his, a few of his past positions are the vice chairman of the WFNS Neuroendoscopy Committee. Please note, Neuroendoscopy Committee will speak about open surgery, but his was vice chairman of this committee. He was chairman, co-chairman, or member of several committees in the ISPN, like Education Committee, Communication Committee, and Liaison Committee. Our other speaker will be Mark Proctor. Professor Proctor is neurosurgeon in chief at Boston Children's Hospital and Frank D. Ingraham Professor of Neurosurgery at the Harvard Medical School. Mark is director of the Brain Injury Center at Boston Children's Hospital and has a lot of functions nationally and internationally in the past or present, so chairman of the board of the Think First National Injury Prevention Foundation, immediate past chairman of the pediatric section of the AANS-CNS, and past president of the New England Neurosurgical Society. So we will hear these two presentations about the different types of craniosynostosis surgery in a historical order. So the first way to operate on this was open surgery. So I ask Professor Di Rocco to start with his presentation pro open surgery for craniosynostosis. Federico, please give us your talk.
Thank you very much. I will share my screen. And I would like to thank Professor Wagner for his kind introduction, and of course, Nerzi Zanon and Sandeep Chatterjee for their invitation to participate to this ISPN webinar on the Clash of Titans. And so I'm very proud and honored to be here and to speak in favor of the open surgery and to show you the advantages of the open surgery techniques in craniosynostosis. I will focus mainly on the scaphocephaly because this is the pathology among the craniosynostosis more common and for which we have a longer follow-up with these endoscopic techniques compared to the open surgery one. And I will not discuss other minimal invasive techniques can be used in craniosynostosis, such as springs or distractors. And I have no conflict of interest. I'm working in a public hospital in France, so no have disclosures. The first point I want to stress on is that the open surgery can be used at any age. There is no age limitation. Endoscopy, as you know, can be only used in a very specific age group in very young children. So just to consider using the endoscopic surgery, you need to have a very early diagnosis of the synostosis and a very early referral so that the child is very young and you can use these endoscopic techniques. Otherwise, you will be limited and open surgery is the only technique that you can use. The second point I wanted to stress is that there is still a limited use around the world of the endoscopic techniques. We question the members of the ISPN doing craniofacial surgery and the members of the International Society for Craniofacial Surgery with a questionnaire, and we asked them what type of skin incision they would use in scaphocephaly, bicoronal or minimal invasive, among other questions. And we had answers from all around the world, North America, but also Europe, Asia, South America. And the answer was a bicoronal skin opening in the great majority of the cases. So there is still a limited use of these techniques, and most of the papers come from centers in North America and some rare centers in Europe. So there is a very limited use of these techniques around the world, as you can see. When we compare to other type of pathology, there was also this discussion about open surgery or endoscopic techniques for pituitary surgery. There was a discussion about doing a sublabial approach or an endoscopic approach, microscope against the endoscope for other type of pathology. But when we go to the pituitary surgery, we all move to an endoscopic endonasal approach. So we are the same surgeon, as was mentioned before by Professor Wagner. So why there is a debate in craniofacial surgery about the use of the endoscope in the last 20 years. So the endoscopic techniques have been used in an endonasal approach for pituitary tumors because it's a maybe different route, it's a different approach, but we want to do the same surgery. And we proved to have the good results, even better with the endoscopic, less complication with an endoscopic approach compared to the open techniques. So we had some objective results and we were able to do the same surgery. But this is not exactly the same for the endoscopic techniques. So why are we talking about endoscopic techniques and minimally invasive techniques? Is this just a matter of scar? Do we want to use the endoscope to reduce the opening of the skin? If that's so, we can also use other techniques like the limited multiple incision technique, which is using some very small incision in strategical points that allows you to have a large opening of the skull, opening at the level of the pterion, opening down at the level of the steryon, which are points that are very difficult to reach with the endoscope coming from the vertex. So is it a matter of the skin or is it a matter of something else? Are we talking only about the scalp or are we talking about comparing different type of surgical osteotomies? So is this again the discussion about strip craniectomies and total wall remodeling coming again? We all know that we started with the strip craniectomy, they were abandoned, we moved to total wall remodeling. So is this another way of putting back the strip craniectomy techniques? And as Professor Gucci would say, the battle between the strippers and vultures. There are a lot of osteotomies. We all know that there are as many osteotomies as craniofacial surgeons. Everybody has his own technique. There is a plethora of surgical osteotomies that can be applied with open scalp technique or with minimally invasive techniques. So the issue is probably on the technique we want to use more than the way we see what we are doing. The issues, we all know them, the problem of blood losses, the problem of the length of operation, the problem of collection, and of course the scar. And when we see the papers that compare the so-called minimal invasive techniques with the traditional open techniques, we have seen that the criteria for were again, the size of the incision, the blood losses, the shorter operation, shorter length of hospital stay, and the increases cost that were put were highlighted to favor the use of the endoscopic technique. But are these good criteria to value the surgery? So if we took an example of a posterior fossa astrocytoma, if we will never be happy to do just a biopsy, even if it's a smaller incision, less blood losses, short and decreased cost. What we want is that the surgery is efficient in treating the patient. And so this is the main question. Are we comparing the good criteria? And when also you see the papers comparing the different techniques, there is another limitation, which is that the period of time we are comparing is very broad. So most of the papers compare the experience of one surgeon in the early 90s to a later experience with other techniques. So most of the series is I was doing open surgery, and then now after 10 years I moved to endoscopic techniques and I compare my two series. Of course, course, the experience of the surgeon has changed, but also the surgical techniques, the anesthesiological techniques. So we're probably mixing apples and oranges. What is more important, we're also mixing different type of patients. And this is a main limitation in all our study in craniofacial surgery. When we see the new cranial vault remodeling data, for example, in more modern series, the complications and the results are very close to those of endoscopic surgery. So there is no such a huge difference anymore. And when we see the paper on endoscopic surgery, most of the cases, the follow-up is very short. So we don't know exactly what is going on the long term. So you see that we have many limitations in our analysis to say that we can draw some definite conclusion. And we have some lack of homogeneous series, as I was mentioning. There are lots of different types of scaphocephaly, but this is true for all type of synostosis. We have different backgrounds. We have familiar cases, genetic cases. We have metabolic alteration that can change our evolution, our results, and of the surgery. We know now better all the different genes that are mutated in this type of synostosis, and some of them can be involved even in the typical so-called isolated scaphocephaly. So we need to continue our studies in order to have homogeneous series to analyze our results. This is a typical example of a suture, sagittal suture, which is closed, but actually, as you can see, is a Crouzon syndrome. But this is other more intriguing case in which you can think it's an isolated synostosis, but only the genetic mutation will show you that there is an ILP mutation. We're talking about hypophosphatasia, and later on, the phenotype will be more evident, but it will take some years to be recognized if you don't do the proper testing very early. So your series or surgical series might be non-homogeneous. This is true for all the metabolic synostosis, which will appear later on, and which have some genes that can be mutated that we can recognize now for a good diagnosis very early. And this problem will stress our difficulties in analyzing and comparing our results. If you don't do your proper radiological examination, you will also miss some cases of Mercedes-Benz type craniosynostosis. You will think it's a simple scaphocephaly, and so your results will not be comparable. And going back to the problem of scaphocephaly, it's heterogeneous also in the shape. So even if we take the so-called isolated one, there is no other type of alteration. Because of the different timing of closure of the sagittal suture, you will have different shapes. With some deformation will be more anterior, more posterior, different nasofrontal angle, different forehead shapes. So even for the scaphocephaly, the problem is not only on the cranial vault, on the sagittal sinus, on the strip of the sagittal suture, but it's also concerned more profound alteration of the skull. If we go back to the closure of the sagittal suture, the shape of the bone over the sagittal sinus is also different. And this probably is something we should study more carefully to classify our type of synostosis and understand better the results we can achieve finally. And also the intradural content will change with CSF alteration that can be found in synostotic patients that are common when you look at them, and you will see that ventricles can be large, pericerebral spaces can be enlarged, and this is true, of course, not only scaphocephalies, but in all the type of synostosis. And so it's important that we properly classify these synostosis in order to understand the results of what we're doing, because there are links between the deformation of the bone and the alteration underneath on the CSF spaces. And the only tool we actually use is the cranial index. And so this is a very poor tool to class our results and to prove that one technique is better than the other, or at least achieve the same results. Because as you have seen, there are a lot of different criteria that we need to analyze. So this goes back when comparing the two techniques, open surgery or endoscopic surgery. What are actually the goals of the surgery? Do we just want to correct the cranial index? It's just a matter of changing the shape. This is what we see in all the papers. The cranial index was improved. So is this actually the only goal? Because if we put an helmet to a scaphocephalic patient with the sagittal closure is closed, his cranial index will be improved. We can squeeze the skull, and you will improve the cranial index. So if these are only criteria, the answer is an helmet. The helmet will be the best technique. There is no scar, there is no problem of surgery, no complication of the surgery, no transfusion, probably no mortality, and all the other aspects like the cost and the length of stay in the hospital and so on will be perfect. So again, I wanted to stress the fact that these are not the good criteria, because otherwise an helmet will do for us the job. If we think that we want to avoid the cerebral compression, we want to achieve a better psychological outcome possible for our children, we need to ask ourselves, can we actually modify the results? Are we doing a surgery just for cosmesis, or do we think that we can modify the function, the outcome, functional outcome in these patients? Because again, if the answer is no, there is no need of discussing about the surgical indication, we just put an helmet. If the answer is yes, we can modify the functional results. We need to understand which techniques will give the best results. And when we see the functional results, comparing large series, this is a series from Paris Renier, more 500 patients, comparing the results of early surgery and old surgery, you all know these series, the better results were obtained in younger children. And this is also more modern series comparing the results, and you see that the full-scale IQ was better when the children were operated on before 6 months compared to after 12 months of age. So yes, there are different neuropsychological outcomes depending, as example, on the age of surgery. So when they compare in the same paper the different techniques used in this patient, they saw that the wall-vault cranioplasty offered a better cognitive outcome compared to the strict craniectomy in the group of under 6 months. So we see that the type of surgery seems to have an impact on the outcome. We can modify our outcome, so it is important that we ask ourselves, how can we achieve the good outcome? And the wall-vault cranioplasty seems to have better results than the strict craniectomy. And so the question is not anymore on the skin opening, is again, how can we achieve good functional results? So can we achieve a proper wall-vault cranioplasty with a purely endoscopic approach? This is the question we need to ask ourselves and to analyze. In other words, what are the functional results after purely endoscopic remodeling? Because again, is the results obtained by the helmet, as it is when you do an helmet with a surgery, or is the results changing the function and improving the function? As we know, we can achieve it with an open surgery technique. So far, the different studies show that the total vault remodeling seems to offer a better long-term outcome for a functional point of view. And the total vault remodeling seems to be easy to achieve with open techniques that allows you to go to the skull base. And this is completely true in older children for which the endoscopic approach is extremely difficult. So again, the open surgery allows you to have a tailored osteotomy according to the type of deformity, and we have seen this very heterogeneous to the age of the child, and this is also very heterogeneous, and you can tailor to different patients different type of osteotomies. And the answer, of course, is not only one technique and one type of osteotomy with this very heterogeneous condition. Endoscopic techniques can function in very specific cases, but yet we need to be sure that the long-term results in homogeneous series are at least comparable with open surgery, or in the best case scenario, superior to the open surgery, which remain the gold standards. So again, be careful about the heterogeneous condition that we're treating, which hinder our analysis of our results, and stop considering only economical or aesthetic factors in the outcome, and not only the cranial index, but more the cognitive and neuropsychological outcome on the long term. And I thank you for your attention.
Thank you, Federico. Thank you for this presentation. Before we start with the question and answer session, we hear the second presentation telling us the arguments in favor of endoscopic surgery by Professor Mark Proctor from Boston. Mark, please give us your presentation.
Great. Thank you, Wolfgang. And Federico, that was a wonderful talk. So thank you very much for that. And my job here today is to refute that. So I want to start by saying, as we might say here in the United States, referring to open surgery as preferred over endoscopic surgery, that we would consider that, sorry, give me one sec. Whoops, we'd consider that fake news. There's lots of reasons that Federico's talk has validity, but I'm going to tell you why endoscopic surgery is really an excellent option for this. So how do we start that? First, I want to say I have no disclosures. If we look at synostosis surgery, it's been a cycle, right? So we started with strip craniectomies in the early 1900s. It turns out those operations were being done for the wrong indications. They were not being done for synostosis as opposed to microcephaly. Back in the 1950s, then we started doing the strip craniectomies. And what was seen was that the results weren't great. They were okay, but they weren't great. And about a third of the patients refused, didn't get cosmetic correction. So thanks to the work of the very famous French plastic surgeon, Tessier, we started doing these much bigger calvarial vault remodeling operations. Well, why ever leave that? Why did we go away from calvarial vault remodeling as the only way? Well, for the same reason we went away from strip craniectomy. The results were suboptimal. There were new technologies. And thanks to the work of David Jimenez and Constance Baroni, we saw that there were other ways of doing it. And what I would argue is that we're no longer in a cycle, but in a modern craniofacial center, you need to have the ability to do both, right? So if you have a newborn with synostosis, you want a multidisciplinary team, and you want to be able to do open cranial vault procedures, and you want to be able to do minimally invasive procedures. And I think probably one of the most valid points Federico has is that they are indeed age dependent. Minimally invasive techniques are good up to about 3 months of age. It often revolves a change in your referral patterns to get the children in early. And the open cranial vault procedures you need if they're greater than 3 months of age. The oldest we ever do the operation on is 4, maybe up to 5 months for mild cases. So you want to have each, and at our center where we do about 100 cases a year, it's about a 50-50 split. Probably a few more minimally invasive procedures a year than open procedures. So why have we been so slow to adopt endoscopic surgery? And this passing fancy or legitimate treatment option will become obvious in a moment. And I do want to point out that unfortunately, despite what Federico said today, France actually used to have a very proud history of endoscopy. So if we look at laparoscopic cholecystectomy, this was developed in France. So I'm sorry I'm talking on the contra side of someone from France today, but a lot of endoscopic surgery began in France. And lap chole, it met early skepticism, but really it's now considered the first line of treatment. And I know it's not exactly comparable, and we'll go over this, but if we look at the early literature on lap chole, here in 1990, laparoscopic cholecystectomy, passing fancy or legitimate treatment option. Again, 1990, lap chole, let us control the virus. Not real favorable outlook for lap chole back in the early 1990s. Lap chole, fantastic, question mark. But then within 1 year, laparoscopic cholecystectomy, evolution, not revolution. The general surgeons started to embrace the technique. And again, this is only a year later, lap chole, threat or opportunity. You can see here, laparoscopic cholecystectomy is here to stay. Few other points. It is clear that the procedure must be performed and further developed. And another point is it requires further experience and analysis, and the results must be reported honestly. So I'm going to try and give you sort of an honest assessment today of endoscopic surgery. What are some of the lessons from lap chole? You shouldn't be doing endoscopic synostosis surgery if you don't know how to do open surgery. And that's the same information you get on lap chole. Synostosis is a complex condition, and you have to be able to treat all facets of it. Back in 2012, I was the lead neurosurgeon on a big international effort looking at parameters of care for synostosis. And I am an absolute firm believer that patients with synostosis benefit from a comprehensive treatment by an experienced team. So it's plastic surgeons, neurosurgeons, neuropsychologists, oral maxillofacial surgeons. You need all of them there. And in our parameters, we came out with a wide spectrum of treatment options going from the prenatal period infancy to toddler age. This is the infancy to toddler. Moving on really across the entire spectrum, 4 to 8, 9 to 12, 13 to 17, and 18 to adulthood. And a few of the things this sort of represents is that synostosis and craniofacial deformities are a lifelong disease, and you need to be prepared to treat the entirety of the spectrum. So let's now look at open cranial vault surgery versus endoscopic surgery. We know open surgery, it's a mechanical operation. The bones are removed, they're placed into the position you want. You try and assure that there's adequate cranial vault volume, and it's an operation I perform a lot of. Big fan of it. Endoscopic surgery, it's not the same as lap chole, right? Because in a lap chole or the pituitary surgery that Federico showed, your goal in both operations at the end is really the same. The goal in endoscopic surgery is not the same as open surgery. It is a release procedure. You're depending on the brain still growing to move the bones out, and it's going to use a helmet to direct that growth. Other people or other methods include springs or distractors. I'll go over that a little bit, but not a lot. And I would say almost conceptually, and this is how David Jimenez looked at the problem, was turning synostosis into a deformational problem. If you can open the bones and then reposition them, you can really hit a home run. I'm sort of a little, I was sorry to see the reference to Dr. Sood's work on just using a helmet. I don't think anybody supports just using a helmet. If you haven't opened the bones and you haven't allowed for normal growth in one plane, then you can't decrease growth in another plane. That's just, I think, really unfounded. And even the person who put out those first papers has abandoned that concept of helmeting alone. So I wanted to look at some of the disadvantages of endoscopic surgery. And these are 5 points taken from a very well-regarded craniofacial surgeon here in the United States, from the great state of Texas. So what are his points? And this was available 10 years ago on his website, and it's available today on his website. Hasn't changed one bit. So correction is not achieved at surgery. So infants must wear a headband. Headbands function similar to synostosis. Procedures are not as effective. There's a risk of a second operation to rebuild holes, and they may be more dangerous because of the restricted view. So first, let me approach these, and then I want to go a little bit deeper because I think most of these arguments are ridiculous. So correction is not achieved at surgery, and infants must wear a headband. Well, that's mostly true. It is true. Why is it not completely true? Because I don't know anyone that helmets for a full year afterwards. The average helmeting period in my series is 7 months, and I never helmet till past a year. But I will then ask, should we be making that choice or leave it up to the patients and families? I don't know the practice all around the world, but I do know in the United States, tens of thousands of kids wear helmets simply for sleep-related changes. So isn't it worth using it for a surgical condition? Do the headbands, do the orthoses function similar to cranial synostosis? No, not at all. They work by providing passive resistance in one area, but they always allow growth in other areas. And you can only do this if the bones are open. So again, the football analogy, I was happy to see Federico using a United States football. I didn't think most of the world was really football fans, but that's not, number one, the head shapes aren't like a football. And two is we would never here in our center helmet someone who hasn't already had surgery. Why don't I like springs or distractors as much? Well, number one is they need another operation to take them out. And two is they only work in one plane, right? They are a two-dimensional, one plane way to correct things, and the head is not two-dimensional. So with helmets, you can get three-dimensional corrections, and if it's not going exactly the direction you want, you adjust the helmet. You can't do that with a spring or a distractor. There's also good evidence that cranial orthoses do not restrict normal head growth in plagiocephaly. Lots of studies out there to show that. And for those, certainly in the United States, and again, I don't know about the rest of the world, would you stop using your helmets for plagiocephaly because you're concerned about their effect on the brain? I don't think you would. I don't think there's any evidence to support that. And these are just various helmets. On the top is for bicoronal, bottom left is for metopic, and bottom right is for sagittal. They all allow growth in the planes that you need the growth in. So are these procedures not as effective, right? That would be a good reason. And I'll get to the functional things as well, but are they not as effective as normalizing the appearance? So I'll reference here a lot my article that came out this year on 500 consecutive patients. These were our first 500 patients that underwent synostosis surgery. We're now up to about 700, but this was 500 with nearly 2 years of follow-up. As you can see, 500 patients, what you'd expect, 2/3 are male, age at surgery 3 months. You see it right there. The mean came out to exactly 3 with a range of 2.5 to 4. So that's where Federico is right. Can't use this on older patients. The weight at surgery, we feel strongly they have to hit 5 kilos. We'll go over the reason why, but basically the risks go down for any bleeding. Operative length, 47 minutes. Anesthesia time, just over 2 hours. We'll go over the estimated blood loss and transfusion more. Hospital stay 1 day, 3% went to the ICU. Helmet compliance, very high. And in this, at the time we analyzed this data, the length of follow-up was 5.5 years. And now it's at 7.5 years for the average group. Here you can just see a little graphic. In the middle, you see 93% of the patients were non-syndromic, 7% were syndromic, half of them sagittal, just as you'd expect. My talk is not just centering on sagittal synostosis, but we'll cover that as well. And you can see we also do syndromic patients, as long as we don't think that their ICP is up at the time of surgery. Endoscopy is not great for elevated ICP because if you have a child with, let's say, a cloverleaf skull, bone is too treacherous to try with an endoscope. Transfusions in our first 500 patients, 6.6%. Now that includes syndromic and non-syndromic, and we'll go over that a little bit higher, a little bit more, but about a 6% transfusion rate in the entire group. Complications requiring surgical repair in this group, there were 7, so 1.4%. This is not reoperations at a later time. I'm going to go over that. I just want to point out this was complications that required sort of an early repair. Head growth data has been tracked. To me, it's one of the most simple metrics we have. It's like if you look at the data on obesity, what's the easiest thing you can do? Check the waist size of people. Check the weight and the waist size. Well, the easiest thing we could do, and we should all be doing regularly, is head growth, and that is maintained in these kids. For all of the kids, it went up except for the sagittal, where it went down slightly. And Federico already showed us the reason for that, because most of these kids are overgrown in the front, and as they normalize into a little bit more of a spherical shape, the head circumference drops slightly from 92 to 85%. The syndromic kids, it's a little bit riskier, right? The transfusion rates are 27% versus 5%. Hospital stay is a little closer to 2 days, and the need for another operation is about 1/3. Let me touch on the, is it just as effective? And Federico, I want to point out, we're not comparing 90s data to 2010 data, where all of these studies are comparing contemporary data. So for sagittal, it's been shown 2018, comparable results. For unilateral coronal, 2019, comparable results. For metopic, this is a study that just came out this past month in pediatrics from the group in St. Louis. For metopic, comparable results. For bilateral coronal, study from last year in PRS, comparable results. Here's one of our APERT children. I would ask how many people think that that's not a really good result for a 30-minute operation, just opening the suture and use of a helmet. Pretty good result. Lambdoid, lead article in this month's Journal of Neurosurgery Pediatrics, comparable results. So I would say from an outcome of the shape, the results are comparable. I will say, Federico, we do not use just cranial index. Obviously, that's only applicable to sagittal synostosis, but lots of different metrics have been compared. Is the risk of a second operation to rebuild holes in the skull higher? Well, short answer, no. We had 2 patients, that's less than 0.5%, who needed repair of a skull defect. I'll point out in the open data, which is the top 2 references, it's pretty clear if you do the operation past 9 months of age, you have about a 1 in 4 chance of having a skull defect if you don't repair it at surgery. So the endoscopic information is much better. Are they more dangerous? Are these procedures more dangerous? People say, I still have patients coming in saying, the surgeon said you shouldn't do this endoscopically because it's riskier. This is our first 100 patients, our 500 patient series confirmed it. That myth is busted. I'm sorry, if you're telling patients they shouldn't have it because it's riskier, you don't understand the procedure. But now I want to go a little bit deeper, right? Because all those things I think they're good things to know, but they're not the real issues. I want to know, who did I need to reoperate it on for endoscopy, both for aesthetic reasons and ICP issues. So the rate there, it was 3.6% in our paper. The average time to reoperation was 2 years. So we extrapolated that the rate is going to be about 4.2% of all these kids are going to need reoperation. So let's just call it 5%. 5%. About half of that, 2.6 was for ICP concerns, and 1% at the time was 3.6% was for inadequate cosmetic results. And 2 patients have required a third operation. How does this compare to the open data? Well, here's a nice study from Washington, D.C. Surgical repair, non-syndromic synostosis, 5.4% risk of needing a second operation, and 30% if you had bilateral coronal. Another study from John Mulliken, one of the real giants in craniofacial surgery. Look at his reoperation rates, 100% in APERT, 25% in Cruzon, 38% reoperation common in open surgery. This is from CHOP, great center. They looked at single suture non-syndromic synostosis. For metopic, 38% were Whitaker class 3 or 4 if you followed them out 1 decade. Just so you know, Whitaker class 3 or 4 means they recommended a reoperation. Well, how about their unilateral coronal patients? Well, exactly the same result. 38% Whitaker class 3 or 4. So there's a clear trend towards worsening over time. How about kids having elevated ICP after surgery? That, to me, that's really the big issue. Number one, again, not just an endoscopic issue. Here's a nice study from Pittsburgh showing 1.5% of kids who had nothing but sagittal synostosis repaired an open technique, developed ICP issues, needed more surgery. Here's a study from Nate Selden out in Portland. 6% of kids with a single suture, non-syndromic synostosis had elevated ICP after open repair and needed more surgery. How do you tell? You look at the head growth curves. Here's a classic open child. Head growth falls off over time, and you know they need another operation. This happens in endoscopic surgery as well, right? This is another APER child who did not need another operation, right? Sutures have stayed open. But here's a Sethri-Chotzen child who did need another operation. The sutures fused. How do we know that? Head growth, right? So the child with APERT started at 38%, went up to 91%. That and the images and eye exams and all the rest told us didn't need another operation. Here's the Sethri-Chotzen child. Started at 16%, went to 30%, dropped back down to 7%, and then we did our CVR. And here you can see nice increase on the APERT child, a decrease on the Sethri-Chotzen child. So another criticism I sometimes hear is, well, you haven't followed your children long enough yet to know, right? Well, then you have to understand how long do you have to follow the children to know, right? So you have to understand brain growth. This is well established. We don't often pay attention to it, but it's well established. 1978, brain weight reaches its adult size 36 months. Another study from 2006, 90% of brain growth by 2 years, closer to 98% by 6 years, and peak volume has happened by 14 years. So yes, if you stop following the kids at a year, 2 years, you could run into troubles, but we don't do that. So what I would say is you need to follow these kids really closely up to 36 months of age. You need to follow them regularly till at least 6 years of age. And for our syndromic kids, we follow them until they're teenagers. We don't stop following them until they're in their adult ages. How do we follow the kids? So my endoscopic kids, I see every one of them back after 4 weeks. We see them every 3 months until a year, and we do annual exams on the non-syndromic kids till at least 6 years. This is head circumference and a development assessment each time. Who does the developmental assessment? If you see at the bottom, we have a full-time neuropsychologist on our team. We're doing regular testing on these kids. We're doing regular eye exams on these kids, and we're doing imaging only as indicated. I do have to touch upon the one study, the single study that Federico quoted was the study from Yale from John Persing, probably one of the most discredited studies in craniofacial surgery there is. What was his result? He found that when he did a complete calvario vault remodeling on a 6-month-old, his average IQ was 117. 117. The average entering class at Harvard is 118. In other words, you can't have any population that has an average IQ of 117. We have done another study with John Persing where we compared our patients to his. There has been no difference. And we have not published that data because that's not data that apparently some people want to see out in the literature. But that was such a nonsense study to have any population have an average IQ of 117, and we simply should not be referencing that article in any reputable discussion. Are there any growth advantages to doing this operation? I just want to quickly, I'll sum up here the neo suture. If you look here on the right, looks pretty normal, right? Normal sutures, normal facial structure, normal eye height, but that's the same patient as the scan on the left. So growing a new suture and getting normal growth over time is something we see commonly in endoscopic surgery. We published it. This is another study from another center showing it for sagittal synostosis. Same patients, right? They develop normal sutures and grow normally over time. Here's one of my patients with APERT. This is a third APERT patient, just to show you how well the APERT patients do. They develop normal sutures, normal growth. And finally, I'll go to the cost and the value, okay? We did a study back in 2012. 3 studies have now confirmed this, that the cost of endoscopic surgery is 40% of the open. And this includes every penny, right? This is the hospital cost, the helmet cost, the parental time, including the time to travel, the gas mileage, the wear and tear on the car to get to and from the helmet. It's still 40%. If we look at value in the current healthcare era, value is outcome that is meaningful to the patient and the cost. I think the outcomes I've shown here today, these are meaningful to the patient. The cost is much less, and therefore the value is a whole lot higher. Are there references to support this? Yeah. When I was at the meeting in Paris this last year, the International Craniofacial Society meeting, I gave one talk, and one of the craniofacial surgeons said, well, if you think your results are so good, you got to publish it. And my response was, well, if you're going to practice craniofacial surgery, you need to read the literature. So we have 24 articles. I have 24 articles simply on the outcomes of endoscopic surgery. We are publishing this, and I think these are pretty high quality references. So in conclusion, we have extensive literature, over 20 years of follow-up, confirms endoscopic surgery is safe, it's effective, and it's reliable. The theoretical concerns about the disadvantages are not borne out by long-term experience. The outcomes are on par with the open surgery, and it's a far better value. And I would argue that this is a technique that should be embraced by craniofacial surgeons. It should become part of the standard treatment algorithm at your center. And if not, the patients very likely are going to start to look at other centers. And finally, I think this is a little ironic, but I have the same photo that Federico had. Federico was not my general combatant in these debates. My general combatant was my good friend, Jim Goodrich. He was really a mentor. And I just want to take a moment to acknowledge both the terrible state we're in internationally right now with COVID, and maybe a moment of silence for my good friend, Jim, who was really a giant in this field. Thank you very much.
Thank you. Thank you, Mark, after this moment of memoriam for our good friend. Thank you for this convincing presentations by both of you. And now let's change to the questions to both of you that have been written in the questions and answer section. And I start with a question by Jamila Benmus from Egypt to Federico. what are the aesthetic results on the long run follow-up in endoscopic surgery versus open surgery in scaphocephaly?
Can you hear me?
Yes,
Yes,
we can.
perfect. So the results, aesthetic point of view, are excellent in both cases. Of course, you can also consider from aesthetic point of view the results with the endoscopic surgery done very early at 3 months of age plus the helmet can even be superior to those that you will do on open surgery done at 9 months. Again, this is not the point in comparing the techniques. The problem is why you're doing the surgery at 3 months or why are you waiting to 9 months. So the aesthetic is only one part of the problem, and as you have seen that the results are, when done with the proper technique by people that know what they're doing, are good in both cases. We have seen some 3D reconstruction that were shown by Professor Proctor that compared the results and they were comparable. But this is only one part of the puzzle. Is again, the question is the functional results. What we want to know is, are we doing good to our patients or not? We're not plastic surgeons, we are neurosurgeons, and we need to see the functional results. So I'm very happy that a neuropsychologist arrived in the team from in Harvard, so we'll have a definite data, and I'm sure they will be nicely analyzed. But we really need to have this data, because otherwise we are comparing the bad criteria.
Okay, thank you, Federico. Mark, would you give another answer or the same one? So aesthetic results on the long run, in the long run with in scaphocephaly in open versus endoscopic surgery.
No, I would completely agree with Federico. I think if you can do the endoscopic operation by 3-4 months of age, the outcomes could be really superior than what we are seeing with the open operation. So I think he and I are quite aligned on that. That it's like anything. We're surgeons. We're not just technicians. We have to know how to select the appropriate patients. But if you use the right criteria, which is predominantly age for endoscopic surgery, then your results could be excellent. And I know, when Federico used to be in Paris, Eric Arnault came to visit and just to see the results, and was very impressed by the results. He saw, I think, 8 or 10 of the endoscopic patients in one day that were coming for follow-up. And he had no argument with the results. He used the same argument. Well, what about a helmet? What about the functional outcomes? I would say the counter argument I would have to you, Federico, on the functional outcomes is you showed the Paris data, which was really quite compelling, that the earlier you operate, the better, right? And I think, I would suggest to you that releasing the bones by 3 months of age is a much earlier operation than doing calvario vault remodeling at 6 to 9 months of age, and might that not have an improved impact? Because right now the only reliable data we have linking outcomes, developmental outcomes to surgery is the age of surgery. I don't think we have neuropsych data on the techniques that's reliable.
Okay, thank you, Mark. There is one question by Erika Jakobsen. It's a question to Federico, but I ask this question to both of you. Is the technique, not endoscopy versus open, but the osteotomies and so on, is this dependent on the shape of the head within some diagnostic entity like scaphocephaly? Does the special individual shape of, for example, a scaphocephalic head influence your type of osteotomies? First, this question to Federico.
Well, the answer is yes. Of course, the principles remain the same, but then exactly the position of the osteotomy will depend on where the suture is closed the most. We all know that in some cases you can have like the saddle deformity of the scaphocephaly, so in the middle there is a big constraint. You will enlarge more that part of the skull compared to the parts that are already large. Then it will depend also on what we have as a compression on the sagittal sinus, and also on the cerebral content, depending on the size of the ventricles and the pericerebral spaces. So we try to tailor the osteotomy to the type of deformity and not to have just a standard fit to all technique.
Okay.
Going back to just to comment again on the functional results, my question is still why we don't have good functional analysis. Okay, there is one paper. It doesn't say what you want, so it's not a very bad paper. I will not argue on the validity of the paper. Okay, but why after 20 years of this technique, we still don't have good functional analysis? I mean, the patients, first patient now should be 20 years of age. So we should have this data. So the question is, why we don't have them? We have them for the open surgery. Why we are not able to have a nice homogeneous series? We take out all the confounding factors, because I'm sorry, if you put in the same basket your cetrochosen, and we know that twist has a high recurrence rate, high risk of ICP. You put APERT, we know the functional outcome will not good, and so on. We need to have a clean, homogeneous series. All the genetic background is tested. We know that they don't have a metabolic problem. We know they don't have FGFR or whatever other gene problem. And we see the results from the functional point of view. We have the psychologists, we have the population, you have the very early, we can compare. We should be able to have this data. My questioning is, why not have this data? And if the data don't say what we want, we say, oh, it's not a good study.
Okay, so these are now at least two questions to Mark, one by
Yes.
Erika Jakobsen and the other by Federico, please.
All right, I'll answer the first question on the osteotomies. So I completely agree with Federico. If you're doing an open operation, like I said in my description, it's a purely mechanical operation, and you have to make your osteotomies where the defect is. So just as he said, I have no argument with that. If there's a saddle deformity, you have to do one type of osteotomy in an open operation. If it's a very bathrocephalic head, you have to do another variation on the operation. So I agree with that. If you were to look at the same thing for endoscopic surgery, that has been looked at. And as Federico said, there are as many osteotomies as there are surgeons. Two separate groups now have looked at doing wide osteotomies and multiple cuts for scaphocephaly versus just a single midline 2 centimeter cut, and they didn't find any difference. This was the group from Johns Hopkins and Children's National Medical Center, and another group from St. Louis. I tend to do a relatively limited 2 centimeter strip craniectomy. So I think it probably matters less for endoscopy because you're doing it early and you're using some adjuvant for the reshaping. With regard to the neuropsych data, so Federico, I think you have a good point. We need to get that data out there. The 20-year history, that's not our group. So I want to be clear. I'm just saying there's more than 20 years of history. The first publication was 1997. We have 16 years of data now. Our first case was done in 2004. We have tested the patients along with Yale. I could tell you that the neuropsych data in our patients was normal, but it's not published yet, and we will publish it. So I agree that should and could be out there, but it's not out there yet. And I also fully agree with Federico that we're sort of in a point in craniofacial surgery where we're able to master the shape, right? One way or another, we could get a good shape, and the outcomes that we have to look at are functional. But I will argue that I believe that the functional outcomes are really just as good in endoscopic surgery. And we don't have the 5-6 decades of work like, was started with Tessier. And that work, if Federico goes back, the looking at the ages and the outcomes, that was after 20 or 30 years of open surgery that data was put out.
Okay, thank you. So I continue with one question by Kausnik Sil about helmet and blood transfusion under the in tropical countries. These are, of course, this is a question a little bit difficult to answer for a Western European or North American guy like us. So the question is, helmet is uncomfortable in tropical countries, and blood availability is also a major issue during summer months. In this situation, do you think, I asked that first to Mark, but also to Federico, in this situation, is endoscopic surgery a better option? Mark.
Yeah, I can't talk from personal experience in tropical countries, so that's,
Yeah.
I can only give you my thoughts on here. I will say, number one, the helmets are not actually that difficult. I mean, an orthotist, and I presume a lot of countries are going to have orthotists that brace all sorts of deformities, spinal curvatures, limb deformities. It's not that difficult to make those. We used to do them just by doing a little cast of the head and then making a plastic mold from that at a cost of about $300. So the only reason the cost of the helmets went up is because big business got involved here in the United States, and they went through an FDA approval, and then the cost jumped up actually tenfold. We tried to lead a movement through the American Association of Neurological Surgeons to overturn that, but we couldn't. We couldn't get the FDA to reverse that requirement. So you can no longer make helmets in small shops the way they used to, but I bet you can in other countries. So the level of difficulty is not that hard. The cost is really not that high, especially if you have it being done locally. With regard to the issues around heat, I mean, I'm not going to tell you that helmets are not hot. They're plastic devices. It gets warm here in the summer. People tolerate them. So, but it may be that you find in your particular environment, it's just simply not practical.
Okay. Federico, do you have a different answer or some other comment?
I mean, there are different materials on which these helmets are made, so there might be one which is comfortable enough. I will discuss more on the blood transfusion, and the data on the blood transfusion are also little controversial, because in some cases the blood transfusion rates are higher in the endoscopic surgery, because you do surgery in a very young child compared to the second group. So also the problem of access to the blood transfusion can be read in both ways, because in some cases, because you're doing surgery when the child is 5 or 6 months, there is less risk of transfusion compared to doing a surgery at 2 months of age.
But I will say that has not been borne out by any published literature.
Mm-hmm.
The rates of transfusion in all endoscopic series are lower than open series. But I could see the argument, and that's why we wait till 5 kilos, but not a single study has shown that the rates of transfusion were higher in endoscopic versus open.
Okay. So let's continue with the... Yeah, Nancy?
Can we continue? Yes. Congratulations, everyone. Excellent lectures. Can we continue about helmet a bit about questions? For example, in low and middle income countries, we can think about the subject. I have traveled a lot with ISPN and World Federation, and some countries doesn't have any craniofacial surgery in all countries. My question is just to know, in USA, for example, who pays for the helmets? Is private insurance or is the family? We know it's a big issue when we talk about commercial questions and surgery and medicine in general. Here in Brazil, we start having a little bit helmets in use. Also for positional head deformities, and also after endoscopic surgery in craniofacial, but a little bit. I would like to have your comments about who is in charge to this cost in the United States for the family and patients.
In the United States, it's essentially universally covered by insurance at this point. It wasn't always the case, but now it's essentially universal.
Okay.
Okay. Federico, in France, also the mutuelle pay for the helmets?
No, in France, people have to pay for their own helmet.
Okay. And the other question is, for how long, Mark, did you recommend, for example, for a young scaphocephalic patients to stay with helmet? 23 hours a day, but for how long?
4 to 6 months.
Yeah, our data across the entire series of 500 average was 7.1 months. So most kids are out of the helmet by about 10 months. Some will go up to a year, never past their birthday. And many kids are out, as Federico said, in 4 or 5, 6 months.
And 2 or 3 change of helmet in between?
Sorry, please.
That was going to be my answer. It depends. We have kids that get by with one, and some kids that need a second, rarely a third. But it depends. As Federico said, there's different helmet materials. Some of them are clear helmets that are very close fitting, and those don't allow for as much growth. At our hospital, we use a helmet that has a lot of padding, and we almost never go past one helmet.
I was saying the same. You need to have one helmet with a good shape and a big padding inside that you can modify when the child grows. So you have
your decision. Sorry, interrupt you.
No, so you pay for only one helmet, but then you work on it during the growth.
Exactly.
Your decision to move the helmet is based on craniocephalic measurements or about image, X-ray, CT, and so
shape,
on?
Overall shape, as far for me.
Okay. Let's continue with a very important question by Sergio Valenzuela about if these two techniques are really antagonistic or rather complementary. And I may ask you, I may add another question, particularly to Mark, but also to Federico. Have you ever seen a surgical procedure where you started endoscopically and during the surgery you felt I must switch to open surgery? Does that ever happen to one of you, to Mark or to Federico?
I'm happy to go first. I have never converted during surgery. I have had one APER child where we had to go back to the operating room and convert it, and that was about 4 weeks later. And it was because of a dural tear. It was one of the patients I included in the complication risk there. And once we had the dural tear, instead of the dura pushing the bones out, the CSF was just pushing out, and I tried to repair it, couldn't get it repaired, so I had to move the bones out. So that's the closest I've got, but I've never had to intraoperatively convert from endoscopic to open.
Okay. Federico, do you have
for me, the intraoperative conversion is, I think you can avoid it because you can have the problem of the bleeding, you can control anyhow, and so on. So it's difficult. We didn't have it, so I don't know. I can try to imagine when you need to convert in case of major bleeding or large dural tear. But these are things that you want to avoid, especially with a closed loop within an endoscopic view. So before the conversion, there was another question about the comparison. Is this complementary? I mean, and I think really the question is a little more philosophical. So the question is not again on how I want to do my osteotomy, the way I use piezo surgery, scissors, or any bone scalpel that you can imagine. The question is what type of opening you want to achieve. And what is fun is that at the end, when you actually see the type of osteotomy that are done, they quite meet in the middle, because some people will do an extended strip craniectomy, and some people will do vault remodeling. But when you see the type of design they're thinking is actually the same. And this is another major issue we have, is that when we compare different techniques, we give them a lot of names. So we have a lot of designs of osteotomies, but also a lot of names that make confusing the results. Because if you compare an extended strip craniectomy with a lot of different cuts, and you compare to the open H technique of Renier, which is considered a cranial vault remodeling, they are very similar. So the main difference, again, is philosophical, is do you aim to go to the skull base? Do you aim to open down to the pterion? Do you aim to have an immediate release? Or, as was mentioned in one of the first slides, do you want to use the growth and use the growth of the child as a dilatation of the skull, and you need the helmet, and things will be more slow compared to the immediate technique. But at the end, the cuts we're doing are almost the same.
So yes, it's complementary, it's different tools given to the same objective, but at the beginning there is a different philosophical view on an immediate result in a more slow result.
And I would agree. I think they're completely complementary, and that's what I tried to stress at the beginning is if you're in a modern center, I think you need to understand both techniques. And I would say I did not do my first endoscopic surgery until after I had done hundreds of open surgeries. So I felt I had a pretty good understanding of the condition, of the ways of treating it. But if I only knew how to do endoscopic surgery, I don't think I would take on this patient population. I think you're doing a disservice.
Yes, definitely. Nancy, we have still time for another question, or when have we to stop? Nancy?
Yes, dear.
We have no still time for another question?
Yes, we have.
Yeah, okay. Please. So there is by Dunia Patricia Quiroga Angulo. Is there to Dr. Proctor first, but also to Federico, is there really a difference between endoscopic surgery and doing only strip osteotomy in scaphocephaly? Is there a difference?
Is there a difference in what you're achieving at the level of the bone? Probably not. You know, I think as Federico nicely said, we shouldn't just be concerned about the incisions, but a lot of families are. I've had families come just because they wanted smaller incisions. I think the technique that Federico described for the multiple limited incisions, that's one described by his father, simply to be accepting that the incision sizes did matter to patients and families. But no, and quite honestly, if you're in an area where you don't have access to scope, you could do a lot of this with a microscope, and in worst case, you could do it just with magnification and good lighting. So we're fortunate to have access to the scope, but I wouldn't say the endoscope itself is a crucial component of doing the minimally invasive operation.
Okay, thank you. And another question is, have you seen complications of the endoscopic procedure when used in a higher age? So if you would try to use in a higher age the endoscopic procedure, is that technically feasible? Has it a higher complication rate, or is it just more difficult?
I cannot answer. They never tried. No,
okay.
Sorry.
Mark?
I would say the same thing. I could tell you sort of philosophically why I don't think it would work, because I do think you need the growth of the brain. And
yes,
I know there are centers that will now do sort of the minimally invasive operations augmented by springs or distractors. But in that case, they're providing sort of a different engine for growth. I'm using the brain as the engine for growth, but if you've got a spring that's going to widen, or you have a distractor which you can open, I can see the argument for being able to do it in older children, but I haven't done that. So I haven't, like I said, if I can't do it by 3 or 4 months of age, we're going to convert them to recommendation for open surgery.
Okay.
Wolfgang, may you continue in later diagnosis on craniofacial? Probably is not your reality. You have probably early diagnosis for these patients. But in some countries, we have doubts about 6 years old scapocephalic patients, 10, 12 years old, not operated until now. And what is the best for the patients? Try to do surgery. Did you have some philosophical questions in mind or not? I know some colleagues doesn't operate any, and we have operated some of them.
I think that patient population will tell you whether or not they need an operation. Are they having headaches or other symptoms? We do neuropsych testing on them. Are they normal, or do they show some delays? We do a formal eye exam. Do they have papilledema, which should be a reliable finding after 3 or 4 years of age, or is that exam normal? And in some cases, we will place an intracranial pressure monitor if we can't be sure. But I would say most children who have not developed a problem by 3 or 4 years of age are unlikely to develop a problem. So it is rare that we have to operate on child who's older than 3 or 4, unless they've just had the problem for many years that went unrecognized.
So I will just nuance saying that it depends on the etiology and the type of complaint. You have the case of very bad head shape that the child can ask himself or herself to the family and to the doctor. People mock at me at school. You didn't want to have surgery when I was very young, but now for me it's very distressful. Please do surgery. And this indication is purely aesthetic, and you will do a cosmetic and aesthetic approach. And of course, it's an open one at that age because the child is able to complain it at least age 8. So you will need to have an open pursuit. This is very rare, but it can occur. Then you have the second situation, which is a functional problem. The functional problem can be on headaches, or it can be on school difficulties and problems. So we have a population of delayed children with a mild psychological retardation or mental delay, and they do examination at age 6 or 7, and that age they discover that there is a synostosis. And the point is, can we improve them? This is the place to neuropsychological testing and all this. For the headaches patient, we also need to understand why they develop the headaches at that age, because some of them are a different population. And in these cases of late decompensation, there are a lot of who are metabolic disease, in which the problem occurs later on during the development. The deformation from aesthetic point of view is mild, but the issue of the ICP, raised ICP and a compression on the brain is very high. And at that point, the surgery is completely different because the shape is limited in its deformation. So you don't need to do a big cosmetic surgery, but you just need to do the compression of the skull. So a parietal decompression, in most of the cases, is sufficient.
Thank you. Just one word about simulation. Did you believe that there is a role for decrease the learning curve for the neurosurgeon and craniofacial surgeon to do, I don't know, 3D printed or other kind of simulation to decrease this learning curve for the young neurosurgeons?
So we did a study with templates because it's very fancy nowadays. You read in all the papers that you print 3D templates before doing the surgery in order to help you doing your osteotomies. And we actually saw that indeed, if the surgeon has a few experience at the beginning, has a little experience, the templates will help the surgeon to do the surgery. If he's already experienced, using this template will get the surgery only longer because he already knows where to cut. And if you start playing with the templates, it will only be a longer surgery. So at the end, yes, for the very young, it can be useful.
That's very interesting, Federico. I could say we do use 3D printing, but not for typical cases, right? If for the average scaphocephaly patient for whom we've seen many patients just like that, I don't find tremendous value to printing their skull. In fact, we generally will not do a CT scan on our patients. The vast majority of our kids do not have preoperative scans. But for unique types of patients, unusual synostoses, encephaloceles, things like that, we print 3 or 4 of them, and we practice the surgery on the models.
If you don't use a CT scan, did you use ultrasound to diagnostic before surgery?
We do use ultrasound, though, I do think that can show synostosis, but I will say, I'd love to hear what Federico says. For the typical scaphocephaly patient where it's a very clear clinical diagnosis, we don't do radiography at all.
May I add here a question, coming back to the diagnostic workup pre-surgically. So as I said, Mark, you don't need in every case, of course, CT scan or like that. Is there a difference in the pre-operative diagnostic workup depending on the type of surgery? Are there differences if you do an endoscopic procedure or an open procedure? Mark and Federico.
If it's uncomplicated single suture synostosis, I don't think there has to be. But for many, as the prior question on older scaphocephaly and Well, there are a lot of the older patients. You're going through a slightly more difficult decision making on whether or not they should have surgery, right? If you have a 9-year-old with scaphocephaly, now do they have bony erosions? Do they have those sorts of things? So I would say there's no doubt we're doing more imaging in the older patients, but it's usually because we're trying to ask a slightly different question. It's not do they have sagittal synostosis, but it's do they have sagittal synostosis that requires treatment.
Mm-hmm. Okay. Federico, any differences in diagnostic workup depending on the type of surgery?
Not really. The only thing is, of course, that because endoscopy is for the very young, you would try to avoid the X-rays in the very young.
Mm-hmm.
You have all your answers with other type of examinations.
Yeah.
But again, I want to stress the fact that this really depends also on where you are. If you're in a major center or in a small center, and you have both pro and cons. If you're in a big center with a lot of cases, you really need to do some examination because statistically you will have some differences, some problems, and because we will need the radiological analysis at a certain point in order to understand our results. As I show you, there are differences in the CSF spaces, there are differences in the ventricles, and there might be other things. So it's important. In some rare cases, you can also have a carry in scaphocephaly. So it's important that we know these things in order to better understand the pathology and improve our knowledge. So it's maybe not fundamental for the single patient, but as a specialty, we need to have this examination.
Okay. So perhaps one other question. It has been asked by Adrian Cáceres from Costa Rica. I don't see it now in the question and answer section, but he asked if in cases of premature fusion of the metopic suture, this is in trigonocephaly, with a strong involvement of the structure of the orbits. Does endoscopic surgery here lead also to an amelioration of the orbital anatomy over time, not only cranial vault, but orbits and cranial base? Mark.
I might refer Adrian to the article that just came out in the journal Pediatrics last month from the group in St. Louis. They did a really nice morphometric study looking at CT scans and the like, looking at open versus endoscopic results in a contemporary side-by-side series, so not historical data. I will say personally, I think metopic is one of the least favorable sutures for treating endoscopically. I think the results are, like for sagittal, I really do think the results can be superior endoscopically, and for metopic, I don't think that's the case. But the group in St. Louis showed really nice results for the orbit, for the orbital retrusion at the frontal bone, and for the hypotelarism. So I think the answer is yes. And if he wants to really look at a good reference, it just came out this past month.
Okay. Federico, another position, or would you agree?
No, the problem was, again, of the trigono is how deep you can go with your endoscope until the nasion, because otherwise you will have a very incomplete results. If you just go on the upper part of the metopic, then you have a catastrophe. So again, the issue is, can you go down easily and deep on the pterion, on the vault, and do without a big compression on the brain underneath? Okay. Because it's still a straight instrument, your endoscope.
I would agree. And I would say not just for metopic, for any of the synostoses, if you do not completely release the suture, you're not going to get an excellent result. So for metopic, you really have to get to the nasofrontal junction, essentially to that cartilage. And you should be able to see the two bones move. You should be able to pry them apart at the end, at the base, and see them move independently.
Okay. So thank you to both of you. We have answered now, or you have answered now, all these questions directly or indirectly that have been asked. And thank you very much for this highly educative and interesting presentations and direct answers to also critical questions. And so I give back now to Nelsi Zanon. He will close the session and give us information about the next Clash of the Titans. Nelsi, please.
Yes, thank you, Wolfgang. Very nice moderation, fantastic. And thanks for the audience. We have more than 120 people with us. Thanks for your time and your attention, your questions, and brilliant answer from Mark Proctor and also Federico Di Rocco. And about certification, certificate for these webinars is a series of webinars. And for those that will be with us for more than 75% of the webinars, we'll have the certificate at the end. We doesn't give a certificate for individuals webinars for each one. And for the next webinar, we'll have a privilege to discuss about epilepsy surgery in children's, callosotomy, with Virginia Meissner from Australia and Jeffrey Blunt from the United States. Will be great, sure, and hope we can have all of you with us. Thanks again, Federico, for your time, your knowledge to share with us. Thank Mark Proctor, excellent presentation too, and Wolfgang, nice moderation. And just to remind us, craniofacial surgery is a team, is neurosurgeon and craniofacial surgeon. We have time to time only neurosurgeons doing even today. And we know when we work in a team, we have a best result for the patient, for us, for safety, and also good results. Thank you very much for all, and see you on the next. Thank you. Bye-bye.
Thank you very much. Bye-bye.
Would you like to have final remarks, maybe?